Hi, everyone. Welcome to the Cardiac Arrest Survival Alliance webinar. We are happy to have Dr. Michael Reed present today, and he will be taking your questions. We have a fast stop at 6 o'clock Eastern. So we look forward to your participation and hope that you find this to be a very beneficial webinar. By way of background, Michael Reed is an interventional cardiologist at the International Heart Institute of St. Patrick's Hospital, Providence. He attended the University of Notre Dame and graduated magna cum laude. He went on to attend the University of Washington Medical School and then completed his residency at the University of Colorado Medical School. He was then chief resident for the year following that when he attended the University of Michigan for both general and interventional cardiology. His focus is on structural heart intervention, and he is also a great guy. So, Mike, you want to expand on that a little bit?
Thanks, Mary. Happy to be here. Hopefully I can be of some help to people who have questions about sudden cardiac arrest or cardiology in general. As you mentioned, I do interventional cardiology and structural heart intervention, but that world overlaps with sudden cardiac arrest commonly. And usually we encounter patients who have a heart attack or a myocardial infarction associated with their cardiac arrest. And our staff works to help those people in that situation. We also work with our electrocardiologists who are involved extensively when there is a primary electrical event. But yeah, it's something that is an important part of our healthcare, and in cardiology in particular. We are happy that your organization is raising awareness and providing this for people around the country. So anything I can do to help, let me know.
Awesome. Thanks for joining us, Dr. Reed. And I think just so that we can facilitate the conversation a little bit, folks, feel free to either raise your hand, speak up, or if you prefer, you can also send either the group or me direct messages of questions you have. I think to just get us started, Dr. Reed, from a physician's perspective, what are some of the things that you're thinking about when you're treating a cardiac arrest patient?
Well, everybody's different. Everyone has a different story and a different circumstance that surrounds their cardiac arrest. Sometimes the patients are in the hospital being treated for an entirely unrelated problem and suffer a cardiac arrest that's witnessed by healthcare staff. And sometimes people are in the community and they have bystander CPR and are delivered to us in critical condition. And so it really depends on the circumstance, but the things that go through my mind when I encounter a patient who had cardiac arrest is, what do we think the cause of this arrest is? Is there something that is reversible? What is the circumstances surrounding it? Is it an elderly patient with multiple medical problems? Is it a younger patient with no medical problems? Was the arrest witnessed? There are certain things that make the survivability of a cardiac arrest more likely from a medical perspective. For example, if you're an elderly patient with multiple medical problems, that makes it less likely you're going to survive. If you have a witnessed arrest with great bystander CPR and a shorter duration of time from the time of arrest to the time of shock delivery, if that is required, that increases your risk of survival. So there's a lot of little things that we want to think about when we're encountering these patients. And our job is to treat them and try and help them survive, but also make sure we give the proper information to the families who are struggling with what to do in this situation and what to expect. So.
Awesome. I know that we have some folks here that have had encounters with, have learned about some of the causes to their cardiac arrest. Justin, I know at the conference recently, you spoke a little bit about your rescuer that came a little bit later on had told the EMS that it was actually a witnessed arrest. Not to put you on the spot, but would you feel comfortable talking a little bit about your experience?
Yeah, sure, I do. Because I went back and looked at my medical records. So I'm a scientist, not an MD. I got a PhD in chemistry, but I mean I can read the stuff and understand it by looking in dictionaries. And I came to realize very quickly that I had been labeled as a witnessed cardiac arrest. I guess you call me survivor, but the truth was I wasn't. And I suspect, because I mean, I looked at my police report. It said, that this person came upon me when I was already collapsed. So she didn't know how long I'd been there, but that story got propagated, and that turned me from a loser into a winner. I was 65 when this happened, but if I'd been I didn't have like a lot of medical issues. I have atrial fibrillation, but that's about it. But it was the genesis of it, I guess, was a heart attack. That's what they claimed after the fact. But I was invested in because I was labeled as a witness cardiac arrest, and I wasn't witnessed. And I'm just thinking of, what is your baseline for saying, well, this probably isn't worth it? Because when I got through the system, my cardiologist was telling my wife that I had like a 5% chance of making it, and I'm going on vacation. I'll see you Monday. And that was it. Because I mean, the writing was apparently on the wall that I was just not going to make it. But I did, and it was largely because a few people in the system invested in me, and they invested very heavily. And I have a great deal of respect for the people that invested in me, and I'm a little bit bugged at the people who just sort of wrote me off. And I'm wondering why people start saying, well, this isn't probably going to make it, so let's not get too invested in this, because that's what brought me out, was the people that did invest in me. I wonder if you have anything to say about what actually drives you in the end to say no longer worth it.
Yeah, it's a good question. We have certain prognostic information when patients first hit the door. And probably the most powerful is the age of the patient and the duration of the cardiac arrest. Those are probably the most powerful. Did they have a shockable rhythm? That's another one. A non-shockable rhythm is less likely to survive. Was it witnessed is an improved prognostic factor. So there are certain things when patients first hit the door that give them a higher or lower likelihood of surviving, just based on all of the demographic information and clinical information we have. And then there are things that we assess over the first 48 hours, like how are they responding to medical interventions? What is happening with their organ systems? They might survive the initial event, but 2 days later, if their liver isn't working and their kidneys aren't working and their lungs aren't working and their brain doesn't appear to be working, then we have more information 48 hours later. So my feeling is everybody deserves a chance in the first couple days. And we know a lot more after 2 days. And usually I tell patients that information when they first, or families when they first hit the door, is there are certain things that help us, give us hope. And you really just got to give it a couple days though, because everybody's different. You know, there are people that surprise us, and it's really important not to make decisions right off the bat. The exception would be, of course, patients who are DNR and have made their wishes very clearly known that they don't want to be resuscitated, or they don't want mechanical ventilation or advanced life support. However, other patients surprise us. Sometimes we come in and say, wow, you know, this guy was down for a long time and all these things. And lo and behold, a week later, they're walking out of the hospital. And so I think everybody gets a chance. Of course, we do everything we can, and then we reassess 48 hours later and see where we're at. But usually by 48 hours, you have a better picture of the likelihood of survival. And it's not just survival, but survival with good quality of life. So those are the kind of conversations I try and have with family members. Is very difficult, but I try and tell them the truth. And I think that people appreciate that. And there are times where, despite the best efforts of the medical system, people don't survive. And there are times when we're surprised and there are miracles. So everybody deserves a chance, and then we just kind of see where the chips fall. And I guess that's the best way I can answer that question. I don't think that any medical doctor or system would write somebody off or not give them a chance based on a police report. I think it's mainly based on other factors, like what are their organ systems operating after a couple of days? What is the acid base level in their blood? There are certain things that I think are predictive, but it's very difficult. I think that people can look really bad when they first to the door and look really good 3 days later. So give them a chance, give it a little time, and most people declare themselves.
Yeah. Actually, I looked a lot worse after 3 days. I was they had to keep me in my medical coma for a month because they couldn't stabilize me. And the whole time they were saying, this isn't working, this isn't working. And it was just the neurologist that said, yeah, this guy's got actually potential. And he was the only one that was right. Absolutely everybody else was wrong. Everybody else was saying, no, this isn't going to work. This isn't going to work. And why are you investing in this? And the neurologist said, yeah, I mean, this looks reasonable. And I actually wrote to him later, afterwards. I wrote him an email and said, so how is it that I mean, I was in the hospital for 90 days. I have no idea how many doctors saw me. I don't remember from 2 weeks before my event until 2 months into my hospital stay. It's all just gone. There's all amnesia there. So I don't know, any of this. But so this guy, this neurologist, was telling my wife, yeah, there's actually, there's a good prognosis here. I think this guy can make it. And absolutely everybody else was saying, no, you need to get prepared. This is the end coming at you. And he was right. He was the one guy that was right and everybody else was wrong. So I wrote him and said, how'd you get it right? And he wrote back that I have no magic powers. I simply did what any reasonable neurologist would have done. And then he noted, many people look at neurological data and get it all wrong, either positively or negatively. But he wasn't willing to take credit for being the only one who could call it out, but he was the only one who called it out. So, I mean, it just makes me wonder, what's the, he wasn't part of the little tiny team of cardiologists that were, looking at my heart. There was a whole bunch of other people as well, and it was just the neurologist that got it right, and he couldn't tell me why he got it right, other than it just, I've seen these for 40 years now, and you're the second person I saw that I saw a real hope in. That was it. So it's very invigorating to me, and also very depressing at the same time.
True. I see Francesco has a question.
Yeah, Francesco, and then Eugenia.
Yeah, thank you, Doctor. I'm in the UK, so you're making good progress, Justin. Nice one. What I don't get, okay, after a out of hospital cardiac arrest, and on the day after I had an ICD implanted because I got reduced ejection fraction below 35. So the guidelines suggest putting an ICD in place in the UK. I don't know about elsewhere. I had 2 arrhythmia nurses come to speak to me about end of life care because I got the NYHA 2 classification. And I didn't understand why they want to speak to me about end of life care, because I'd not been told anything. And it wasn't and I sent them away because I was looking forward to going home. So, I never understand why palliative care and end of life are lumped together, because they're 2 separate specialities. So a few days after I got home and my discharge summary come through the post, it informed me something I didn't know, that I had, MYHA to heart failure. For what the bloody hell is heart failure? Anyway, I took no notice of it. I know what could take place with fatigue, tiredness, breathlessness, and that's why I'm interested in increasing my CO2 max and looking at the relationship between RR interval and the respiratory sinus arrhythmia with the heart rate variability. And I kind of got involved with back here in England with some projects that are going to deal with the relationship where it may improve. I don't know if that's part of your research or innovation that you do across there, looking at bringing out an enhanced cardiac pacemaker that can connect the RSA to the RR interval to increase, I don't know, up to about 20%, the capacity for the structure of the heart, not to heal itself, because I appreciate it won't, but to be given an assistance in a way that is more manageable than a left ventricle assistant device for somebody that might have a 10% reduced ejection fraction, waiting for a transplant donor, but unfortunately pass away before one's identified. I'm just thinking of how innovation can improve the quality of life for people once they find out that their structure of their heart isn't as good as what it was, bearing in mind we're all getting older, and the vast majority of people is kind of like my age when have a cardiac arrest. Thank you.
Well, it sounds like you have quite a story and a lot of insight into this process. It's true that reduced ejection fraction is one of the predictors of sudden cardiac death, whether it's related to coronary disease or whether it's just related to non-ischemic cardiomyopathy, which is reduced ejection fraction with normal coronaries. And heart failure management, both acute heart failure management and chronic heart failure management, is one of the priorities of cardiac care worldwide. There certainly are medications that have been proven to improve ejection fraction, improve congestive heart failure class, and prolong survival. It's quite remarkable. Just in the last 10, 20 years, we've seen a lot of improvements in patients' survival and quality of life with the implementation of these medications like beta blockers and ACE inhibitors or angiotensin receptor blockers or aldosterone antagonists are just a few classes of medications that certainly help in this regard. In addition, you mentioned device therapy. we have cardiac resynchronization devices that are basically pacemakers connected to defibrillators. The defibrillators are implanted in patients who have a severely reduced ejection fraction, less than 35%, in spite of adequate medical therapy and in spite of revascularization of obstructive coronary disease. And since those patients still have an increased risk of sudden cardiac death, even later, implantable defibrillators are recommended. And if they also, at the same time, have some electrical changes like a left bundle branch block on their EKG or changes in the electrical conduction system compared to the left ventricle to the right ventricle, when that defibrillator is implanted, they often will receive what's called a biventricular pacemaker defibrillator, and that can help with heart pump function as well.
Yeah, thank you, Doctor.
You bet. You bet.
Maybe we can move on to Eugenia and Joseph, if you don't mind muting.
Always assumed the explosion that day in April 2004 was caused by the end.
Mute Joseph. There we go. Yeah, Eugenia, if you want to ask your question.
Sure. Hi, everybody. My name is Eugenia. I'm 57 years old, and this is my daughter Eugenia and my son Carmine. We're in the car. Sorry, it's so dark. Carmine, I had a cardiac arrest July 30th this past summer, and my husband had passed away 3 weeks before I had the cardiac arrest. I don't know if I already had congestive heart failure from like a TTN gene that I was born with that I never knew that I had up until 20 years ago when my children were born. And I don't know why the cardiac arrest hit before at that point, right after my husband Steve had died 3 weeks later. I was home alone in the evening with my son Carmine, and we had a defibrillator at home, and but we never ever had to use it, but we just always had it just in case, because I have a left bundle branch block as well. And so I felt like I was going to faint, and I called upstairs to my son and I said, Carmine, I think I'm going to faint. And that's all I remember. And he found me and he gave me 2 shocks and called the paramedics, and they gave me 3 more shocks, and they gave me epinephrine and I believe magnesium. My potassium was like 2.1. I don't know why the potassium was so low. I mean, this is like later I read my results to see what happened later. I'm so grateful that I have my full brain ability. You know, Carmine had got the shock to me within the first minute. The paramedics, I think, were at the house within, I don't know, like 4 or 5 minutes, because we were right down the street. And they implanted a defibrillator inside my chest, and it's been since July 30th, and doctor was like wondering, it doesn't feel safe to be alone. Like, I'm afraid to be alone. If Carmine wasn't there that night, they said, you know, I would have certainly died. The kids were just starting college. Carmine took a year off to stay home to be with me, and Eugenia went to school. I said, both of them can't just stay home and just look at me. You know, I really can't afford to have someone watch me 24 hours. So I was wondering, do you think the ICD, I know you don't know me and can't maybe really say, but do you think having an ICD, could help? I mean, I know they did all those other things. The paramedics did 3 extra shocks and Carmine did 2 shocks, and then they did oxygen. They put a big pump on me. They were pumping me. Carmine said like a, CPR pump at the house, and intubated me, and, gave me potassium and magnesium and all these other things. And now I feel like all I have is just this little implantable thing. I'm just afraid. And I don't know, maybe over time that'll go away. I don't know. My ejection fraction was down to 15 to 20%. And then my last echo, now they said it's like 35%. I've been taking like a lot of like CoQ10 and D-ribose, and along with some heart toprol and some heart medications and stuff like that. So I was wondering, also I was wondering too, do you ever do like remote visits, like Zoom visits, like, if, like to have a consultation? I live in Connecticut, so I know we're not in the same state. So sorry guys, it takes like so much time, but that's our secret.
Well, I'm glad you're on the Zoom call, and you certainly sound like an amazing woman, and you have an amazing family. So I'm sorry you went through that traumatic event, but I'm also happy you're alive and that your family saved your life. So um, it's a great story, and you're obviously very intelligent, and in spite of everything, you didn't just survive, but you're thriving, and you're here to kind of tell us your story, and I appreciate that. With regard to your questions, you have an implantable defibrillator. It's designed to shock you if you have a recurrent event. And it's small, but it is very effective. In fact, probably more effective than an external shock. So I want to give you some reassurance there that the purpose of the defibrillator is to save your life in the event that you have another arrhythmia. I can't tell you what to do with your family or how to, be monitored, but part of the advantage of the defibrillator is that it gives you freedom to live your life and freedom to exercise, and give your family freedom to leave you alone so that they can live their lives as well. So I would encourage that. Yeah, I don't have a crystal ball. Maybe you'll have another event in the future, but the defibrillator is there to shock you out of that. And you may not have another event the rest of your life. There are people who have defibrillators that never go off. So my sense is continue your medications and get your device checked on a regular basis, like I'm sure you are. Eat right, exercise, and try not to let this completely consume your life and your family's life, because you got a second chance, and I think that all of you should take advantage of that. And your ejection fraction is higher now than it was before, so you're at lower risk for cardiac arrest. Plus, you have a safety net in place that's not 100% foolproof, but it's very effective at shocking people if they have a life-threatening arrhythmia. So I hope that helps.
Thank you.
Good job to your family for saving you.
Yeah.
Thank you.
Yeah, every story is different, and not everyone survives. So it's always wonderful when we can encounter people that have been through this and lived to tell the tale and help raise awareness. It's more common than I think anybody realizes, and I don't think that the idea is to live in fear. The idea is to live with gratitude that we're here, and we can share our stories. And yours is a story of survival, and mine is a story of trying to help people. And Mary's and Alex's is a story of trying to raise awareness. So we're all in this together. So it's comforting to know that there is a lot of people who are going through these experiences and sharing it with other families and other survivors. So thanks for tuning in.
Go ahead, Francesco. And
No, it's just a quick question, Doctor. Does the American Heart Association, what's their recommendation for the implantation on your side of the pond for ICD? Is it, I don't know, below ejection fraction, reduced rather than mildly reduced, or preserved at 35 or below? Or is there other factors to consider as well?
Well, there are two scenarios in which we would recommend implantation of a defibrillator. One of them is for secondary prevention. And what that means is you've had a cardiac arrest and you didn't have an immediately reversible cause. Those patients get a defibrillator regardless of their ejection fraction. An exception would be if someone comes in with a major myocardial infarction, a major heart attack with 100% blockage in a coronary artery, and that was associated with a cardiac arrest, If the blockage was fixed and the ejection fraction improved, those patients wouldn't receive an implantable defibrillator because there was an immediately reversible trigger for their cardiac arrest. However, if those patients had a persistently low ejection fraction, below 35%, then after 3 months of taking appropriate medical therapy and allowing the heart muscle time to recover, they would receive a defibrillator. Likewise, anybody who has not had a cardiac arrest falls into the primary prevention strategy. And this includes patients who have coronary disease or don't have coronary disease, patients who have an ejection fraction that's reduced less than 35% in spite of adequate medical therapy for 3 months at least. Those patients are at increased risk and would receive an implantable defibrillator for primary prevention, so as a prophylactic defibrillator. Of course, the exception would be people who are who don't want to be resuscitated. I mean, there are patients who are elderly and have peace with the decision to not have a defibrillator. So, long answer. The short answer is, if you've had a cardiac arrest, we're probably going to recommend a defibrillator. If your ejection fraction is less than 35%, in spite of medical therapy, we're going to recommend a defibrillator.
Yeah, that sounds quite reasonable. I thought that was what nice guidelines in the UK. I thought modelled itself with the AHA and what they do in Japan. And but yeah, it sounds good. The other thing I was gonna ask, if that's okay, quickly, is if you had a patient that came to you and they weren't taking any let's say anticoagulants because they got mechanical heart valves. I'm not relating it to mechanical, so they weren't taking any warfarin, but they wanted to take, because they've got heart failure equally, and they wanted to take, let's say, coenzyme Q10 to see if that could improve the action of the mitochondria to produce ATP and, not feel the effect of fatigue, tiredness, and breathlessness. What would your advice be?
Well, I want to make sure I understand. It's a two-part question. If a patient had a mechanical heart valve and they weren't taking their anticoagulation, I would strongly recommend they take their anticoagulation. That's the answer to the first question.
Yeah.
The second question is, if a patient wanted to take coenzyme Q10 to optimize the performance of their heart, I would not have any objection to that at all. I think that there are certain medicines that have been proven in large-scale randomized clinical trials to be effective in prolonging survival or improving heart pump function. And then there are certain medications that may have benefit, but have not been proven in large-scale randomized trials. There's probably a lot of medicines out there. There's probably a lot of natural medicines too that are beneficial, but we just have not proven it.
Yeah.
And so identifying what benefits patients and what doesn't is always a challenge. But coenzyme Q10 is, I would consider, a very innocuous medicine. So it's probably not going to hurt. And there may be some benefit. It just hasn't been proven to the point where our guidelines recommend that.
Thank you. It's confirmed my thoughts on coenzyme Q10. Thank you.
Mike, Dr. Reed, sorry. A lot of people have expressed concerns that their cardiac arrests they couldn't determine the cause, they were idiopathic. And so, that presents a whole level of extra concern because they don't know what caused it. Do you have any comments about that?
Yeah, that's difficult. I mean, in some ways, there's more closure if you know exactly what the problem was. I can imagine if there's no clear trigger that people would be confused. Why did this happen to me? And, what exactly is the etiology? Is my family at risk? Those are questions that come up. In terms of causes of cardiac arrest, probably the number one cause is coronary disease causing a reduced ejection fraction, or what we call ischemic cardiomyopathy. Those patients have scar on their heart, and the scar on the heart is a nidus for an arrhythmia. So that's the number one cause. So if someone has a cardiac arrest, we always want to consider the possibility of coronary disease. The number two cause of cardiac arrest is probably a reduced ejection fraction in patients that don't have any coronary disease. We call that non-ischemic cardiomyopathy, and that can be caused by a number of different triggers. One would be toxins like alcohol, excessive alcohol intake. Another would be genetic predisposition that can be tested for. And probably half the time, we don't even have a clear answer. We call it idiopathic non-ischemic cardiomyopathy, which are semantics. So what that means is your heart pump function is reduced. We don't know why. Maybe those people had a virus in the past that burned itself out, but left them with some degree of reduced heart pump function. But half the time, we don't know. We just know that their heart pump function is reduced. And regardless of whether it's from coronary disease or from a genetic problem or from toxins or from a virus or from idiopathic, the treatment is going to be the same. Those people are going to be treated with proper medications, and a defibrillator will be implanted if appropriate. Occasionally, we see people who have a totally normal heart pump function. They have totally normal coronary arteries, and they have totally normal heart valves, and there's not any clear trigger whatsoever. And that's probably the most difficult to sort out. Those patients would be treated with the defibrillator, but they may not receive the same medications because most of the medications are designed for patients who have reduced ejection fraction. There are certain genetic tests that are sometimes performed in that situation to identify genetic predispositions, but that sometimes just poses more questions than answers. So it's a difficult problem.
Thank you. Emily.
Howdy, everybody. Can you hear me?
Yes.
So I just I won't over introduce myself, but I had multiple diagnoses prior to cardiac arrest. I had cardiac arrest almost 8 years ago. But I was initially diagnosed in, I think, 1982 or 83 up with mitral valve prolapse. And so I was a teenager. I was like 12 or 13 or so. And then I made it all the way up to my 40s, and coming like maybe late 30s into early 40s, I started to get like what I now know were probably arrhythmias. So I'd get this like dizziness, and I would get that like the white light thing that people talk about. I get this like roller coaster vertigo. So I started going to a cardiologist, and at one point I was being screened like once a month, then we went to once a week, trying to figure out like what was going on. And a heart monitor would show kind of like, sometimes it might show arrhythmias, but then I would go get like a EKG, a electrosonogram, and they wouldn't really see the arrhythmia. And then on the monitor, it would show the arrhythmia like the next day. So I did that for like 2 years with a cardiologist. I was probably like 38, 39 or so. And then I stopped, or maybe I was like 40. I made it, whatever year it was, but I made it to 46, and I went for another series of screens, and I had a double cath test, and they diagnosed me with Takotsubo cardiomyopathy, which is like the way I interpreted it, it's not exactly to mitral valve prolapse, arrhythmia, but it was emotional distress. And at that time, I was involved in a divorce. Like I was splitting up from my first marriage, and the stress of that was like so intense. And I'd go into these like dizzy spells, and it very likely that those were arrhythmias. 46 years old, I have a very stressful week at work. I have interactions with my old marriage that weren't fun. And I go into cardiac arrest, like I have a solid week of just misery. At the end of that week, I go into cardiac arrest. When they screened me, they saw evidence of like a recent heart attack evidence in the lower section of my heart. They saw 2 scars. Whatever, they couldn't see they saw the mitral valve prolapse, but they didn't see the arrhythmias again. I get an ICD a week after that. Then from 2016 to 2018, in the first year, I was great. It was amazing. I was like on this like high escalating, like getting myself back physically. And then I started taking a nosedive in that second year. I go back to cardiology. They're trying to screen what's going on. They're like, well, we see that there's these arrhythmias, but they couldn't reproduce that on a stress test. And I guess in the year of 2017, I took like 3 or 4 stress tests trying to find out this arrhythmia. Finally, I go to this one checkup, and they're like, okay, we're going to run you for a long time on the treadmill. They kept getting me on and off the treadmill onto the table, and finally they get me on the table one time, and then they saw the arrhythmia. And what they diagnosed it at that point, like, oh, this is intermittent arrhythmic mitral valve prolapse. So it would be like this, like only once in a while. They couldn't understand what exactly the conditions were that caused it, but they're like, okay, this was like my regular cardiologist. He said, let me call you this afternoon. He calls me back. This is like a couple days before Thanksgiving. I get a call from a surgeon. He's like, hey, can you come into surgery next week? And I'm like, whoa, hold on a second. So they had me, it was Thanksgiving, and I had this, like, this was in Mount Sinai in New York. And I have like the David Adams mitral valve team, and I have his his partner, I guess, is Javier Castillo. And they're both like this mitral valve clinic, right? So like, okay, can you come? When do you want to come? As soon as possible. I ended up going on January 1st. They repair the mitral valve. And then after that, like they did like an annuloplasty on it. From 2016 until now, like I get these, like every once in a while I get an arrhythmia and then it corrects. But the thing that I'm comfortable with, like how I'm doing and my diagnosis, but the issue about it, the main key word in my diagnosis was intermittent, because I could never quite get a consistent evaluation of what was going on with. They saw the mitral valve prolapse, but the arrhythmia, they couldn't really see. It was too off pattern. They couldn't diagnose it, and as a kid, they didn't, I guess they wouldn't medicate it. I didn't know what that was about, but I just wanted to mention the intermittent part was the part that was really the most dangerous for me, was that they couldn't diagnose it. So
yeah, it's a complicated story. It's a unusual problem, but it has been described. In hindsight, you had Takotsubo's cardiomyopathy at one point that is related to stress and probably related to a surge of adrenaline in the setting of that stress. But the mitral valve prolapse has been there your whole life. And it has been described that mitral valve prolapse in certain people can tug on the papillary muscle, which is connected to the heart pump, the left ventricle, and can be proarrhythmic. And it sounds like that's what they thought you had, and repairing the mitral valve is the therapy in that situation. So it sounds like you had that done. With regard to arrhythmias in general, intermittent arrhythmias, it's a challenge, because most people who have palpitations or even dizziness, they don't have life-threatening arrhythmias. 99.9% of the time, it's something completely benign. And sifting through the haystack to make sure we don't miss people who truly do have a life-threatening arrhythmia that can lead to a cardiac arrest is always a challenge. We have tools to monitor heart rhythms, but they all are snapshots. So we can get an electrocardiogram that gives us a 5-second snapshot, or we can do a 48-hour monitor, or we can do a 30-day monitor. There's even implantable monitors that can be left in the skin underneath the skin in your chest for 3 years. So we have longer monitors, but if you don't have an event while the monitor is in place, it's very difficult to know what the source of the palpitations are, what the source of the dizziness is. So it's a challenge, but hopefully we can keep listening to our patients and trying to identify the best way to work them up. We can't just put a defibrillator in everybody with dizziness and palpitations, of course. We got to really find a way to identify the people who are at highest risk. And, it's interesting too, people who don't have a diagnosis of a life-threatening arrhythmia but have a lot of anxiety about it. You could purchase defibrillators. We purchase smoke detectors. So you can purchase a defibrillator and have it in your trunk of your car or have it in your house. If you don't have a diagnosis of cardiac arrest, but you have a lot of concern about your symptoms, that's one thing that I've advised patients from time to time when we don't have a diagnosis of an arrhythmia that would justify an implantable defibrillator. But if they're concerned enough, they can purchase an AED and have it in their house.
So I'm recognizing the time. I want to make space for anyone else that's had a question or has wanted to ask a question, hasn't had the chance yet. Go ahead, Emily.
Can I just respond quick to Eugenia before, who I felt like she left on a cliff a little bit with some of the things she said, because she just had her rescue, it sounds like. So the first year is really tough, and the first couple of months are tough, and it's kind of personally I was afraid to go to sleep for months. I was afraid of I'd went to sleep, I wouldn't wake up, and I live with my rescue, and I wouldn't leave her side for months and months, and I get that. And I think that's I don't know how to solve, how to. There's a lot of just a lot of soul searching you have to do for that, but it's reasonable. It's terrifying, the first couple of months that you think it's going to happen again, and with having the ICD, I kept going back to my doctors. I'd call them again. If you say every 6 months, try to schedule every month if you want. If it helps you to get that reassurance, or even the phone call back to them, say that ICD is going to put you back in safety for the thing that happened, in the cardiac arrest. That's just I just wanted to say that to you. I hope that you feel better,
Thank you, Emily. Yeah, sometimes I actually feel like I feel like a weird rhythm happening, and I don't know if you guys ever saw on TV that thing, you put your two fingers down and it's like a e-cardio or something it's called, you can buy, and I always, whenever I do feel like I'm having a weird rhythm, when I do that, I'll see it will say, long QRS or, unclassified or something like that, so I do feel when the rhythms are going weird, but nothing has shocked me or anything. And then there are days, when I'm fine, and, I do kind of forget about it. And, but then when those weird feelings come, it's scary, and so that's why, I'm getting a little bit better about, telling the kids, get out of here for a little while, and, going out alone. Sometimes I get worried. Yeah, when the doctor had said for everyone to, if you feel worried, to have a defibrillator, we always had one at home, even though I never had an implantable one. And I'm so grateful that we had one, because Carmine was able to start it within 1 minute. He was just upstairs and he was listening to music, and I'm like, I don't know, it was just like a miracle that he heard me call up. And so I think, maybe people, if they can afford to have one at home, they maybe should, I know it only helps if you have someone there with you, but I'm really grateful for the whole hospital team and all the paramedics that did everything. And I don't know if the stress of my husband dying 3 weeks before brought it all on. We won't know, and I just feel bad that the children almost lost both of us within 3 weeks. So I'm just really grateful, just a little worried, that's all. Thanks, guys.
Well, I think you have an amazing family, and I'm really happy that you're alive and that you're here to tell us your story. I think that it may be that your husband's death triggered higher adrenaline levels in your bloodstream that made you predisposed to an arrhythmia that you otherwise may not have had. We'll never know. But that's certainly plausible
Doctor, I have
because,
one question.
yeah.
I had a question. My potassium level, was like 2.1 or something when they brought me into the hospital. I don't know, why that was. I mean, I don't know if it's too much information, but I had a urinary tract infection, and I was on like macrobid antibiotic. And so then later on, I was looking up, and it said sometimes maybe macrobid is like in the macrolide family, and then maybe that people that not everyone. I mean, I've even taken macrobid in the past, but they were saying maybe because I had the genetic like TTN gene that maybe the macrobid could have caused the abnormal rhythm, certain antibiotics or something like that. So now I'm like terrified if I would get a urinary tract infection because I don't know what antibiotic. I know I don't ever want to take macrobid again, and I don't know why my potassium dropped down so low. So I didn't really know, like, should I be getting like potassium tested? I don't really know why it went so low, and I don't know anything, what antibiotic would be safe. And I asked the doctors, what antibiotic can I take? And they're just kind of like, oh, well, we don't really know, it's, I know I don't know for sure if that macrobid caused it or if it was just a storm of everything, or I don't know, but I was just wondering, what do you think do you guys ever like test your potassium or anything like that?
Yeah, I think I don't know if the antibiotic was involved or not. I do know that certain antibiotics can affect your EKG and may predispose people who are otherwise at risk for arrhythmias. Penicillin antibiotics generally don't do that, just FYI. Amoxicillin or ceftriaxone, those kind of antibiotics don't usually do that, but fluoroquinolone antibiotics like levofloxacin or ciprofloxacin or certain antibiotics like clarithromycin or azithromycin can potentially do that. So it's something to remember in the future if you are receiving any new prescription, antibiotic or otherwise, to ask your doctor, is this going to affect my risk of cardiac arrest, or is this going to affect my EKG? Can we double check and just make sure? So that's a reasonable question. I think it probably was a combination of events for you. Your ejection fraction was low. You were grieving your husband, and your electrolytes weren't normal. It sounds like your potassium was low, which makes you more likely to have an arrhythmia. That's a really low potassium. I don't know why. If there were other medications you were taking that maybe lowered potassium, like diuretics can do that, for example. That's why we often prescribe potassium supplementation for patients that are on diuretics.
Yeah, that was
Certain
the only
diuretics.
That was the only thing
That was the only one.
yeah, so I didn't know, why that was, but they were giving me potassium at the house, at my house.
There's certain, just biological processes that will lower potassium. For example, if someone has, this is kind of gross, but if someone has diarrhea, they're more likely to have low potassium. So there's certain things that will do that, but you've had your potassium checked since then, I imagine, and
Yeah,
hopefully it's in the normal range.
Normal range now, yeah. Yes.
Well, when managing people with congestive heart failure or cardiomyopathy, it's standard to check electrolytes from time to time, especially if they're on diuretics that can affect their kidney function or affect their electrolyte function.
It seems like we have one last question in the chat. If I know we're at the hour, Dr. Reed, but Joe asked if you had any thoughts regarding supplementing with magnesium.
Yeah, so this is something that we're taught in medical school, that if the potassium levels are low we always want to check the magnesium levels first, because if the magnesium levels are also low and then you take potassium supplementation, the potassium supplementation is less effective. So ideally, in patients with cardiomyopathy, we want magnesium levels in the normal range and potassium levels in the normal range. You can take oral magnesium at home if you want. It's not going to harm you, and it's reasonable to do on a regular basis, but I would consult with your doctor to make sure that it makes sense. You can also have your magnesium levels checked at the same time as your other electrolytes. But typically in patients who have congestive heart failure or cardiomyopathy, we want magnesium levels above 2.0 and we want potassium levels above 4.0. So those are two things that we monitor in the hospital and outside of the hospital, but taking magnesium supplementation to keep your levels above 2.0 is perfectly acceptable. But I would talk to your doctor about it.
All right. Well, we're just about time. Thanks so much, Dr. Reed, for joining us. And I think given that we're all in the CASA, community, feel free to, if you have any other follow-up questions, to send direct messages to any of us. I don't know, Mary, if you had any final words before we end for today.
No, I just want to thank you, Dr. Reed. That was really informative. And I like this idea of having an open forum, and just so people can ask questions. I like this format, and you're very helpful. So thank you so much.
Happy to help. Thank you.
All right.
Happy holidays,
Thank you.
everybody.
Thank you.
Happy holidays, everyone.
Yep.
Take care.
You too. Bye-bye.